Our next speaker will be Dr. Dan Gombas. He's going to speak on indications for intra-arterial chemotherapy for retinoblastoma when we do it, and he is coming from the Retinoblastoma Center of Houston.
Thank you very much, and thank you for the organizers to really, emulating what some other people have said, expanding the cohort of people here. I'm an ocular oncologist by training, and I'm going to talk a little bit about the role that your field has in the management of my most primary common intraocular malignancy of childhood, which is retinoblastoma. Key disclosure here is that I am a member of the Children's Oncology Group, which is an NIH-NCI-sponsored organization for pediatric trials, and I was co-PI of the intra-arterial protocol treating children with retinoblastoma with intra-arterial chemotherapy. So the management of retinoblastoma goes back many decades, and historically there was an enormous amount of consensus. We went through an era where surgery was the main approach. In the 60s and 70s it was external beam radiotherapy, and then into the 80s intravenous chemotherapy, and there was very good consensus from center to center throughout the Americas and Western Europe. In the past decade, there have been two huge advances in the field which has altered that trajectory, and that's the role of intravitreal chemotherapy, where we inject chemotherapy directly into the eye, and intra-arterial chemotherapy, and the focus of my talk will be the latter. This is not a new technique, as with all things. If you go far enough back, you'll find that it's been around longer than most of us have been around. So this technique was actually developed initially for this disease by our colleagues in Japan. Kaneko and Yamane, I believe is how you pronounce the interventionalist name, developed what he described as selective ophthalmic arterial infusion over 35 years ago at the Tokyo Cancer Center, in which a balloon catheter was inserted just distal to the ophthalmic artery, and melphalan was injected into the eye. And eventually that information got to the American literature. It was sort of buried in the Japanese literature and eventually made its way with our colleagues at Memorial Sloan Kettering, initiating that transition from use in Asia to the United States. Before I go on and talk about the management, it's important to have a little bit of an understanding of how an ocular oncologist addresses this disease. It is, unlike other malignancies, one that is based on clinical diagnosis. So a child will present and an experienced ocular oncologist will make the appropriate diagnosis. Like other cancers, there's a staging system. Historically, we used a grouping system. You may recall the Rees-Ellsworth classification. That is no longer used. So for ophthalmic cases, we use what's called the ABC or Murphy classification system, which goes from the letters A to the letters E. And this is an important thing for those of you managing this disease. Basically, the letter A is small intraocular tumors. As you progress to the letters E, you have larger tumors, eventually involving the vitreous being the jelly of the eye, significant disease, so you can see these little spots, E being the worst case, very advanced disease, least likely to salvage, much less salvage with vision. And so in the past 5 to 8 years, what we've seen is that intra-arterial chemotherapy has transitioned from something that was historically an experimental approach to something that now no longer requires IRB approval, and that there is an increased use and facility among our colleagues in your field using this modality. That's also been associated with reduction in some of the toxicities that I will be talking about. There is no shortage of cases that have been described using intra-arterial chemotherapy in retinoblastoma. This goes anywhere from orbital disease to intraocular disease, can be used as a primary modality, a planned adjuvant therapy where you start with IA and you start with intravenous and then go to IA. Consolidation, where your initial regression is not satisfactory, and then ultimately salvage. And this can be done also in a unilateral or bilateral setting. This is one of our earlier cases where really a child whose remaining eye would have been historically destined for enucleation, but with intra-arterial chemotherapy it was, in our eyes, really miraculous. And so it sort of harbored the potential strengths of this modality. The current modality and the current management evolve, so you're not going to have one person, one speaker tell you this is how everyone manages retinoblastoma. It is not uniform, and it does vary from center to center. But there are guiding principles that I anticipate sharing with you today. One of the biggest reasons why there's so many variances is because we are constantly battling with the three overriding principles within the management of retinoblastoma, which is save the child's life, save an eye, and save sight. And sometimes there's such a battle to save the child's eye and sight, we lose the most important aspect, which is saving the child's life. Complications, some of which you may not be aware of, are ophthalmic, so significant ischemia to the eye. This is a child who has successfully saved the eye, but look at all that choroidal ischemia. So this is a paper from our Swiss colleagues. Our colleagues in Philadelphia have commented on cases where, again, the tumor is beautifully treated, pre-treatment, post-treatment, dead tumor, unfortunately dead eye because you've developed an artery occlusion to the eye. You're more familiar with some of the toxicities you may see during treatment, like vasospasm. There are also well-described stroke cases that have occurred after intra-arterial chemotherapy, both transient and permanent, and patients can develop grade 3 and 4 myelosuppression just from administration of this drug to the eye. So grade 3 and 4 neutropenia are to be expected. This is an unpublished abstract that was from the group in Siena in Italy describing shortened globes, so smaller globes after intra-arterial chemotherapy. Again, these are successfully salvaged, but it remains unclear at what cost. Late toxicity is always a concern. This is a patient cohort, remember, that is at risk and prone to other tumors in life. So exposure to fluoroscopy, as small as it is significant. Downstream chemotherapy, i.e. chemotherapy that is ultimately absorbed in the CNS, is unclear, and concerns about hypoxia are some of the reasons why there's enormous variance in treatment. But the biggest concern that many people have is the inability of focal modalities like intra-arterial to address high-risk histopathology. So if you have an eye that has significant choroidal disease, there is good literature to suggest that that child is at risk for metastatic disease. Many clinicians feel those children should be given intravenous chemotherapy to address that, although some believe there may be a role in intra-arterial chemotherapy. It's somewhat easier to agree among centers where intra-arterial chemotherapy is not indicated. It's generally not indicated for the best and the worst eyes, because the eyes with really small tumors we can treat with focal modalities, and the eyes with very advanced disease probably should be enucleated. Also, those that are exceptionally young probably aren't the best candidates. This is a child with orbital disease, again, not a good candidate for this approach. Unilateral disease, there is good consensus. Groups B, C, and D, remember that treatment trial, that grading I told you, A through E, so in the middle. These are excellent candidates for intra-arterial chemotherapy, and they are alternatives to enucleation and intravenous chemotherapy. This is a child that years ago would have been enucleated, tumor everywhere in the eye. When we're done, not only have we cured the tumor, we've maintained vision. Truly revolutionary. The scope of the drugs that are available for this, a little bit out of the scope of my talk, but basically there are three main drugs that are available, melphalan being the most effective. The bilateral aspect of this disease is really the most complex. There is no consensus. There are some centers that still advocate intravenous chemotherapy for these patients. There are others that advocate intra-arterial chemotherapy. And therefore, given the complexity of this, it really varies from centers that give tandem chemotherapy, one eye and then the other eye, versus other centers that give intravenous chemotherapy and only give intra-arterial if they need consolidation or supportive care to address salvage. Can't emphasize enough the importance of a multidisciplinary tumor board, so if you're going to do this sort of treatment, I would advocate that the group meet and review this. So in conclusion, IA has certainly been a significant advance to the management of this disease. It can be used as a first-line therapy, particularly for unilateral disease. Bilateral disease, a bit more complex. You will get differences of approach, but it's highly efficacious when one looks at the historic treatment outcomes. Thank you.